Welcome to Endo Battery, where we are sharing our endometriosis journey and learning along the way. This podcast is in no way meant to diagnose or give medical advice, but a place where you can gain knowledge and information that can help you to not feel alone as well as become your best advocate. We want to learn with you and support you wherever you are in your journey.
Thanks for joining us. I'm Shelby.
And I'm Alana, and we're Endo Battery,
charging our life when endo drains us.
Welcome back to Endo Battery, and today we have the privilege of being joined by Dr. Jose from the Center of Endometriosis Care in Atlanta, Georgia. Dr. Jose, thank you so much for being here and taking the time to talk to us about all the different things that you are passionate about. Mm-hmm. Can you tell us, first of all, why you got into this field specifically, and a little bit about yourself?
So basically for me, it was about myself. Born and raised in the Caribbean, Dominican Republic, raised, corn-fed, slapped. Then came to my residency in New York. I was an attending in Women and Infants Hospital in Providence, Rhode Island. I got into the field. I decided to do a minimally invasive fellowship because I had, even though I was already practicing for 4 years and I did pretty complex cases, what I thought was complex cases for a regular GYN, because I was in a very, very busy practice. So when I was there, I saw some patients that had endometriosis. Obviously, Providence, Rhode Island is like the second coming of Dominican Republic in the US. Like the population of Dominicans and Latinos in Providence is just astronomical. I think the population at that time was like 1.4 million people. It's the population of Rhode Island, and 0.4 is like Dominicans.
Wow.
So, or at least Latinos and people from Cape Verde and all my different islands, and from Africa. And so I had patients that had endometriosis or that had chronic pelvic pain, and I saw them for consultation for hysterectomy. And I did kind of the whole song and dance about, here's some Lupron, here's some birth control. It's in your head. It shouldn't hurt that much. So all those little things that I like that medical abuse and medical neglect, I was the guy that did some of those things because that's what that's how I was trained from New York. Right. And I heard other attendings also say those things. Mm-hmm. The worst thing I ever heard an attending tell a patient was, I remember in consultation, she said something about, like, she had a lot of pain with deep penetration. And I think that it was a female attending at the time. I think she said, well, you need to get a partner with a smaller penis. And I was like, holy crap, that was rough. But then she kind of like blew it off as a little joke, and I was like, oh, that stayed in me, right? So it's stuff that, like, a lot of different things, and
so if it stayed with you, it stayed with the patient.
True.
Yeah.
True. So then, when I was in Rhode Island, I saw some patients that had endo, and I did the whole song and dance, right? And I had one particular patient that's kind of the reason why I'm here today. Her and her mom were both Dominican, and I remember it was a Saturday morning. We were in clinic. That was me. It was me and my girlfriend, and she was in Michigan doing her fellowship. So then Saturdays, in order for me not to be bored out of my mind, I would just please ask to be in clinic Saturday morning, so at least I have something to do. So then Saturday morning clinic was there, and I saw her for a follow-up. She had endometriosis. We went in. We tried to remove what we could. It was complex. I thought the surgery went phenomenal. Her pain did not improve. Gave her Lupron. Horrible side effects, like gave her add-back therapy and all that stuff, did not improve. I said, well, I can't do anything for you. Just go to GYN oncology. There's nothing else. Like, I'm sorry, I can't give you more narcotics because now you're pain seeking, right? Mm-hmm. She went there, and basically what she was told by GYN oncology is like, well, we can take out your ovaries and everything and your uterus. And she was like 24 or like early 20s.
So,
and I was like, and then she came back, oh, I don't want to do any of that. And why can't you help me and stuff like that? And I was like, well, I don't know what to do. So then she disappeared and then came back like a month and a half later or something like that, after she tried to commit suicide and thank God, was not able to. And she came back to clinic, and she basically told me, like, why don't you want to help me? Like, I'm Dominican just like you. And that stuff killed me.
Yeah.
That stuff killed me. And that's kind of why I decided, you know what, I had to realize that I was not a good surgeon, that general OBGYNs are not trained to do complex endo cases, and then I have to figure out a way to get more training. So that's where I found like the fellowship And thank God through that fellowship, actually, then part of my fellowship was here at the CAC with Dr. Sonervo. After I finished here, I wanted to stay in the endo world, because the one thing I realized is that in order to get good, right, at this, the only thing you need to do is you need to drop everything else. So you cannot be doing pap smears and breast exams and delivering babies, right? And then have a 7 to 10 hour surgery the next day, because you can't do that, right? For bowel or for diaphragmatic endo. So definitely one thing had to give, and OB is the thing that had to give. So then when I finished here, part of that fellowship, after I finished my fellowship, I stayed here a couple of more months, was training with Sonervo. And after that, then I joined a past fellow of his called Patrick Young in St. Louis. And then when he retired, then I became the director of the Center of Endo there. And well, he didn't retire, but when he went over to like focus on fertility and do NAPRO technology and all that stuff, then I stayed as a director of the center. And then, family reasons and stuff like that, I decided to move down here to Atlanta, Georgia.
Yeah. It's interesting because you and I talked a lot about this at the summit. We talked about just serving your people, because it's so different there than it is here. But then we also talked about all of these, the what's been called the gaslighting, and you only know what you know.
Yeah.
And that's the challenge, is how do we translate what you know, like you specifically, to other OBGYNs? And not most doctors are going to put themselves out there to continue their education, to look deeper into it, or let seemingly little things affect them and deter their path. But you have stepped out and said, nope, I'm going to change this. I can't do this. This is not fair for people of the Dominican Republic. That's not fair for people in the Caribbean. It's not fair for women here to have to deal with this. And you don't want to carry the weight of that on your shoulders. Like, how do we talked a lot about that, actually.
So, one of the things is, at least what happens in my own country that I love, and, born and raised, corn-fed and slacked. So one of the things that I love about the country is the fact that, like, it's how warm the people are, right? So when I chose a place to practice after I graduated, I wanted to be in a community like Providence, Rhode Island, that had a very high Latino population, so that I can, kind of serve my team, my people, but patients from all walks of life as well, right? And then what I realized was that doing fellowship and coming out of it, then that's when I actually really saw the absolute disparity in complex gynecological care in my country versus here in the US. But not only in my country, because when I was training here, I saw patients from Europe, from the Emirates. Like, I saw patients from Canada, London, Brazil, Peru, Mexico, Dominican Republic, Martinica, like patients from all over. So it's a very international practice. So I also love that aspect of this, because there's a lot of patients that are from some of these places where, unfortunately, the insurance companies have a lot more power. Like, one of the things that happens in our country is that you have doctors that want to do what's right for the patients, but the insurance companies are not going to cover something. So imagine a gynecologist that knows that a patient has an ectopic pregnancy, but they use a device in able to cut, like an electrical device, in order to cut the fallopian tubes. So, which is very efficient, right? You could use either electrical mechanical energy or actually electrical. And what happens is those devices have a certain price point, but insurance companies, some of them, are not covering those devices. So then you have a patient that has something that could be resolved laparoscopically in 10 minutes. And she has to get open like a C-section to just remove a little bit of blood and cut out a fallopian tube and be done with it. Right? Because insurance companies are not going to cover it. So if insurance companies are not going to cover it, what's going to happen to the hospitals? They're not going to invest in the things that upscale to allow more of these procedures to be done, to drop down the cost, so that we can offer it to everybody else. Like, I'm working on on a group right now with a group of doctors in the Dominican Republic to start. Initially, I wanted to do like teach people to do complex GYN surgery, but then I realized that the number of laparoscopic tubal ligation for the population is like 2%. So it's like less than 2% of the people that want to get a tubal ligation have to get open for them. Then we need to start like at the absolute basics. So I'm working with a specific group to basically go to teaching hospitals and teach new residents, right? Teach the new generation, hey, this is something that it's simple to do. After you graduate, a couple of you can get together, you can buy the machine, you can go to a center and do these procedures safely if we teach you and give you support for it. So I think in a couple of months, we're going to be doing like in a public hospital, we're going to be everything for free for the patient. We'll do probably anywhere between 40 to 50 tubal ligations laparoscopically just to teach the residents of that particular institution how to do those procedures safely, right? The more they know, the better it is.
Right.
So
Well, that's what we talked about, though, was like the fact that most doctors don't know. And so even more so in countries that don't have as much accessibility to the knowledge, it's harder to educate them, but that's really where it starts. It starts at getting them the proper education from the base up.
But I mean, the thing is that in medical education is expensive. And when you have to go outside and do cadaver courses, which is something that I do and work with a big team of doctors from Canada, Brazil, and Mexico, and Peru. When we work with these guys and we go to SLU and to use their cadaver labs to teach all these things, it's great. But it's in order to learn how to do these procedures, you have to learn on cadavers first, and then translate those skills into people. Right. But that takes a cost, but also taking into consideration that you're going to invest in this type of medical education, and then you're going to go into your country, and then like a very few amount of people are going to be able to afford what you're going to do. Then patients are going to be like, no, right? So that's the biggest thing. The more people we get trained to do this, the more we can actually affect change, so that insurance companies are forced to cover procedures that are safe for all patients, right? And one of the things that we need to definitely get away from, especially in the Caribbean, is like when you have a patient that has suspected endometriosis, oh, let's do a laparotomy, let's open her up to see if she has endo. So it's like you're going to have a C-section scar to see if you have endo, and then what happens when they go in, which basically, so think about that. The only patients that go in for that type of surgery are usually when they have endometriomas. So when you have bilateral endometriomas and everything is frozen, they do this. They open up and they go, holy crap, this looks really bad. We can't do anything else. Just suck the cyst, cut some stuff out, and then we're done. So she had a laparotomy. She's not going to get pain improvement, and she's going to continue with all the endo because nothing was removed properly. And
That's
on top of that,
in the U.S.
And on top, well, exactly. So I mean, I'm not saying with this, I'm not saying that it only happens in the Caribbean. It also happens here. But like, and on top of that, because they open her up like a C-section, a lot of the time they infect the laparotomy scar. Over time, then she's going to have scar endo as well, and they're going to say, "Oh, I don't know how that happened," and I was like, "You caused it."
Well, it was interesting because at the summit, you and Megan Wasson were talking about that, and it was like a light bulb went off for me.
Fascinating,
because I had the same thing.
Yeah, so we did talk about like the causes of endo, right? Like, or how does it spread? And one of the things is, it's our fault. It's surgery, right? You open up. I mean, if it's a patient that has like scar endometriosis for a laparotomy scar for her C-section, that's impossible to prevent that. Like you do a lot of things because like when you take the baby out, and you take the placenta out, the placenta is stuck to the endometrium. So some of those cells can fall and then get on the laparotomy scar, and when you close everything, like then she can have a foci of endometriosis at the scar, and you can't prevent that. And sometimes when you're doing like complex GYN cases and you're putting laparoscopic ports, like if you're removing all that stuff from there, it only takes one cell to get into that port site that you did to cause it. I was actually going to publish a video, or was thinking about publishing a video last night, like around 1 a.m. I was looking at like reviewing videos and stuff like that. And I remember that I did a case on a patient that we had to take out her belly button.
Mm.
Like, and it can be traumatic, right? It can be
Right.
traumatic for lots of patients to like not have a belly button. Hey,
Even though it doesn't necessarily serve like any
it doesn't have a purpose.
It
Right?
just,
After your point, it doesn't have a purpose, but
right.
you know, it gives you some sense of normality.
Well, and then, so we talk about like the C-section or like the incision, but then the other part of that too is like adenomyosis, or what is the cause of that? Because a lot of people have the theory that it's when you have a C-section or when you,
so
it gets in the lining and things like that.
So it's not necessarily when you have a C-section, but so the issue with adenomyosis is that it's kind of poorly understood how adenomyosis actually happens. But we do know that there's a genetic component to adenomyosis, endometriosis, and actually fibroids. So they do share around 20 to 30 genes in the last couple of studies. There's a lot of stuff that's coming up, a lot of data on adenomyosis, but basically is the uterus is divided into three different layers. So the thing with adenomyosis is that we don't necessarily know how it happens, right? We do know that there's a lot of genes that are shared between adenomyosis, fibroids, and endometriosis, right? But what if we're going to go like to the basics of what adeno is? We got to talk like 2 seconds quickly about anatomy, right? So this is a sonogram of a uterus, right? And the uterus has multiple different layers. Has the inner layer, or stratum functionalis, has the stratum basalis, which is the thing that grows every month, and then that's where it grows and it sheds. And then you have the muscle layer of the uterus. So the way that I talk to my patients about this is like, hey, the uterus is made of two different components, the inside lining. So right, it's endo, inside, metrium, matrix, as we Latinos call the uterus the matrix, but that's like another story. And then the muscle of the uterus is myo, right? Latin myo for muscle, so myometrium, muscle of the matrix. So the muscle of the matrix has separate layers as well. And it has basically the inner myometrium, which is called the junctional zone, and it has the outer myometrium. So that outer myometrium is kind of what the outside layer of the uterus, and everything is covered by the wallpaper of the abdomen called the peritoneum. Yeah, peritoneum over the walls, peritoneum's over your internal organs, like covers everything inside of your belly except the ovaries. Right. So what happens in adenomyosis is that the myometrium, the inner layer of the myometrium, which is basically the stuff that's most in contact with the stratum basalis, gets damaged. It could get damaged because of like surgery, like you can have let's say a myomectomy. And because of the myomectomy, the way that they got in, the layers got a little separated. So a little bit of the endometrium got embedded into the muscle of the uterus, and that can cause pain. So another good way to explain it to patients is like, you know that when you get a vaccine shot in your muscle, like you can get pain from the shot, right? But what happens the next day or 2 days later, you're like at home in your computer, and then your husband or your partner, whatever, gives you a glass of water, and you do this to go get it, and you're like, ah. So that racing of your arm basically gives you pain. Why? Because you have water inside of a muscle
Right.
that's not supposed to be there. So it's around the cell. So when you contract that muscle, what happens? The pressure inside of that muscle goes through the roof. And that basically sends you a pain signal to your brain saying, hey, there's something wrong in that spot, but you know that it's because of vaccine. Now, what happens in adenomyosis is that that because the muscle of the uterus, the way that the uterus is layered, right, is like an inverted U, right? So you see the U right here, and this is the vagina that's going to be coming out of your body. So what happens? So when you have that muscle, right, the inner walls of the uterus are kind of flat. So when you're bleeding, if you cut your skin and you're bleeding a lot, how do you stop the bleeding? You hold pressure.
Right.
But if you're bleeding from your vagina, how do you stop that bleeding? You can't just magically put your hand in there and stop it, right? So what happens? So the uterus basically takes the front wall of the uterus and the back wall of the uterus, and it squeezes it together, right? So it depends on those inner walls to be flat. So it squeezes it together, and those cramps that you girls get is basically what? Is that uterus is clapping away inside, stopping all that bleeding, or
You
trying
make
to
it
slow
sound
down
much
that.
nicer than it actually is.
Yeah, you do make it sound nicer than it actually is.
No, I know. Well, I mean, I don't have a uterus, but I'm imagining in my mind.
No,
that,
right, yeah.
Right. But like, you know what I mean? So it's like basically it's squeezing the life out of itself. So it slows down the bleeding. So you don't bleed to death, right? So when you have adenomyosis, when the muscle is contracting, imagine that that muscle it's supposed to look like this on the left side, right? But in some cases, it looks like the one on the right side, which is called diffuse adenomyosis. And adenomyosis has also been known to cause like neovascularization, so presence of a lot more abnormal blood vessels in that muscle and around itself, right? So then you have this portion of the muscle that's full of little black dots of blood, right, that bleed into the muscle. So every month you get 50 to 100 shots of flu shots into the muscles of the uterus. And then you expect the uterus to clap. So then, you know, pain goes through the roof. And that's when it's diffuse. But in some cases, you can have one single portion of it, like of the uterus, that has adenomyosis, and it's called like a massive adenomyoma. And when that happens, that mass continues to grow. And because it's not like a fibroid that's encased in a capsule, when you go in to cut into it and pull it out, you're just pulling like spongy type of muscle, what makes it really difficult sometimes to have to close those defects. But you have to, because it can continue to grow, and it can deform the uterus significantly. It can impact pregnancy, right? Because we do know that adenomyosis can impact pregnancy negatively, just like endometriosis and some of these other conditions can. But the reason how adenomyosis can impact pregnancy, it could be very different. It could be it could be because where it's located. It could be located like right here at the ostia, right? Or the opening to the fallopian tube, basically preventing sperm from getting into that side of the fallopian tube. Let's say that you only have one fallopian tube, or the adenomyosis is such that is basically deformed those outflows of that of your fallopian tubes, and it can cause them to be shut, right? Some cases of patients, then one of the issues with adenomyosis is like the symptoms could be so varied. So it's also, I mean, it's one of the evil sisters of endometriosis, right? And those evil sister, number one is adeno, number two is IC, or painful bladder syndrome, right? One of the things that you do is when you do an MRI, you see that there's thickening of the muscle layers. And sometimes it's most commonly in the posterior muscle layer of the uterus, right? So this is an MRI. You can see the pubic bone over here, and you can see the bladder of the patient in white, right? So this is the front face of the uterus, right? Which is right on top of the bladder, which is kind of the reason where when the uterus grows into your belly button while you're pregnant, your uterus is right on top of the bladder. So, you know, that's what they feel. But also you have the inner lining, which is this thing that looks on this line that you see on the inside of the uterus. But notice the back wall of the uterus, how big and thick it is. Right. So this is one of the things that we can see when we do an MRI for adenomyosis. So it's super important to know. Sonograms can kind of tell us, but what happens on the inner lining of the uterus? Like right at where the placenta is going to attach itself, right? Because when you're pregnant, the pregnancy happens at the level of the fallopian tube and ovary, but then the pregnancy has to travel back into the uterus. So when it travels back into the uterus, the pregnancy has to do what? Attach itself to the inner lining of the uterus to make that connection. So that connection between the placenta and the mother should be perfect, very synchronous. Now imagine that instead of finding a good hand, you find a whole bunch of stuff while you're making that connection.
Right. It's not
right. So that is one of the reasons how adenomyosis can cause infertility. It can cause miscarriages, especially first trimester miscarriages. And I was reading a patient sent me a comment on Reddit today about like she has massive adenomyosis and she's not been able to carry pregnancies past 10 weeks. Right. And every time she gets pregnant, like 10 weeks in, she may lose. The longest she's been able to carry is 10 weeks, I think, 10 weeks and 6 days. So almost 11. But the thing is that imagine a uterus that's full of some of these holes that you see here.
Right.
So then when that placenta attaches itself there, this is a little pocket of blood. And these are holes on the uterus and lots of different polypoid tissue that basically when you touch, it bleeds. When any type of pressure, it bleeds. So if you have bleeding between the placenta that should be like attached perfectly to the uterus and the mother, all that blood there causes an issue and can separate that little baby placenta that's trying to impact itself and cause it to die, right? So, for example, in this particular video, This is Dr. Sayhar from Spain, for example, and he did you can find this on YouTube. He's a great surgeon from Spain. And he does a lot. I mean, he does so much hysteroscopy, right? So look, he's just going to touch the inner lining of the uterus. And you see that bleb?
Yeah.
Boom. So imagine if you have a placenta that's growing on the other side of that, and any type of pressure can throw that clot behind that little baby placenta trying to impact itself.
Yep.
Look at that little black spot right there as well. As soon as he touches it, two more bloody spots come out.
Yeah.
And that can cause, can affect pregnancy significantly.
Yeah.
So that's kind of one of the things of adenomyosis that we need to try to understand and focus on. But it's one of the reasons how adenomyosis can cause infertility.
Right.
Not even considering the excruciating pain that patients with adenomyosis can feel.
I feel like that was worse than my endometriosis pain. If I'm being honest, like that because I had so many biopsies. I had a uterine biopsy. She was like, something's not right in here. So she did multiple biopsies, come back and she's like, oh, I think you have adenomyosis. And I was like, oh, okay, what's that? I knew I had endometriosis. I didn't know I had adenomyosis. I didn't even know what that was. And she's here taking samples of everything. And I don't know. She was like, I don't know how you had kids. I was like, well, I don't know either. But
what did I say? What did I say when I saw you over there at the Endo Summit? Just those miracles. How are they doing?
Yep. They're fantastic, and they're miracles. They're true miracles, because having the adenomyosis was by far the most painful when it came to cyclical pain for me.
So,
like it was excruciating.
Yeah.
But it was all the time, and I bled constantly. And that's
one of the things. Because like your uterus is trying to stop your bleeding.
Right.
Cramping, and estrogen is ramping up. But now you have inside of the walls of the uterus, you have bleeding that's staying there. And whenever your uterus causes this, that causes local inflammation on the inside muscle of the uterus.
Right. Yeah.
Which throws your pain like through the roof, right? So that's why that pain happens. Now, it's important to understand that adenomyosis and endometriosis are highly associated too, so they can co-inhabit.
Right.
But we tell patients that, hey, a hysterectomy is not the treatment for endo.
Right.
We don't say that for adenomyosis. Adenomyosis, the ultimate treatment is actually to do what? To resect it, to either, depending where the patient is in her reproductive journey. Right. You can do surgery to cut out the adenomyoma if it's local. If it's diffuse, meaning it's the whole uterus, then you can't make 50,000 holes inside of the uterus, because that actually can impact negatively while you're trying to get pregnant. You can get a higher risk of uterine rupture and other procedures. Right.
Yeah.
Other things that happen. Now, if you have one adenomyoma and you can go after it, and your doctor feels confident that they can remove it, then great, try it. But make sure that doctor is a highly skilled GYN surgeon.
Yeah.
Right? Highly skilled GYN specialized surgeon that does these type of procedures yearly. Right? Because that's one of the things that we have. This is how we're going to have to differentiate endo surgeons from other surgeons, right? The amount of what the average, I think somebody told me recently that the average number of hysterectomy that a GYN does a year is 5.
Really? I thought it would be higher.
I have to look at that data again, but it's not that much.
Interesting, because that was an option all along in my journey. And she, I mean, I think my OB/GYN, she was like, oh, I specialize in endo. She didn't.
Yay.
But she saw a lot of people with it.
I'm finding a lot of those issues now. So now that I became, one of the reasons I post most of my content in Spanish is because I want to educate people in the Caribbean, Central and South America as well. There are great educators for that, but I also wanted to be a voice in that, even though I had I still have massive imposter syndrome. So therapy.
We all do.
Yeah. Vitamin therapy is so important. It should be one of those food groups that we need to get every day.
Yep.
So I decided to post most of my content in Spanish. I'm doing some stuff in English, but most of it is in Spanish, just so I can educate a lot of people in the Spanish-speaking world.
Right.
So that they know that sometimes they are going into their GYNs with all the tools that they need to kind of inform them about what's happening with them and give them like one of the things I tell patients is like, hey, it's great if you have a pain calendar for the last 6 months before you go talk to your GYN. So that way they're not gonna, oh, we're gonna try this and then wait 3 months and then just you keep a calendar of your period, when pain, what happens, what's associated, everything that's happening around your period is so important because it's maybe that's not the only thing that can give you pain in your pelvis. Like I always talk about the 5 things that give you pain: bowel, bladder, uterus, and the 20,000 things. Endo is a part of that, but you have muscles, pelvic floor muscles, and you have pelvic floor nerves. So you have 5 things quickly from in your pelvis that can give you pain. So we cannot rely on endo being one of them to be the only cause of that. So the key to success is having patients see a team of doctors, a multi-center approach on what's happening with your pain and how can we address it. Understanding that, like hysterectomy is not the treatment of endometriosis, but in some cases, removing the uterus does help. But the problem is that we have to take that stand because I cannot see another 25-year-old from middle America that's castrated like a dog. Because she has massive endometriosis. And they take out the uterus, they castrate her, and they leave all the endo there. And guess what happens afterwards? Whenever they go back and talk to their doctor, hey, you know what? My pain is a little bit better, so I'm feeling great. But my vagina feels like a 90-year-old woman.
Yes.
It's dry as a bone. It's like the Sahara Desert down there. Whenever I see when I see my partner and he or she is naked, I'm like, put that away. I'm not in the mood.
Yeah.
Right?
But yes,
what happens? You feel really bad for your dried up 90-year-old vagina, and they give you estrogen therapy. It's bananas. So that's the reason they castrated you in the first place. And what happens later when you go back to them and say, hey, doctor, that I had a total hysterectomy, right? And you go, yeah, we took out, yes, you did have a total hysterectomy, but I'm having a regular period. And they go like, no, that's not true. I'm like, wait, I'm telling you that's true. I'm bleeding every month. How are you gaslighting me into thinking that what I'm feeling is not, like I'm using a pad or a tampon and it's full of blood. How is it not true? Oh, fine, come over here, let me evaluate you. And they put a speculum in and they see a little redness and say, hey, did you have sex recently? Oh, it's probably nothing. And then a couple of months go by and we found out that you have a new nodule in your vaginal cuff. And then you're bleeding irregularly from that nodule because they left a whole bunch of endo behind before they castrated you, because they concentrated on what? The uterus and your ovaries. But all the other stuff that was around it
floated on in.
Oh, yeah, my lord.
Or like when you're having a bowel movement and you're bleeding every time you have a bowel movement. I talked to 3 people this week that were like, I bleed on my period, but it's out of my rectum.
God.
I mean, and we hear this, and we aren't doctors, by the way. Like, we're just talking to other people that have endometriosis, and this is what we're hearing, or probably suspected endometriosis, because it's cyclical a lot of times too. And they're like, I never associated bowel with endometriosis. I'm like, you and a lot of other doctors. So this is where you need the specialist.
So remember that stuff that I told you about that patient had surgery, she had a hysterectomy, and she was put on birth control, on hormones after that. So this is one of those cases, right? So but what we're looking here is basically this thing at the top is the bladder. Correction, this thing at the top is the vagina. The bladder is on top of that. And this is a rectal probe. So this is the rectum. So you can see how close the rectum and the vagina are.
Yeah.
Right. So whenever time you see from this black line to the tip, that is 1 centimeter.
Interesting.
So just so that you have an idea of the scale of what we're looking at, right? There's 1 centimeter. This is a uterosacral ligament that we're seeing over here, right? Even though there's no uterus, but now when you have a hysterectomy, you attach that to the vaginal cuffs, the top of the vagina, in order to prevent the vaginal cuff to kind of invert itself and have a prolapse. But this patient, between the vagina that's at the back of the vagina that's here and the rectum, she has this ball,
Mm-hmm.
right? And
Yeah.
then, like, we just start getting after it. It's gonna be 10 minutes, it's too long, but we just start getting after that ball. And when you put a speculum in the vagina, it just looks like beautifully pink. And she has one pimple that's a little red because every time she was having vaginal bleeding, and she called, like, hey, I'm having vaginal bleeding. She was called, okay, you can come in, like, but she went and saw them after the bleeding concluded. So after the bleeding concludes, then that little black or red spot would kind of like heal over because
Right.
she is between periods. So it doesn't necessarily have to be that way. Right. So, which is kind of the same reason why when patients have like are having rectal bleeding and you're going to get a colonoscopy, they say, oh, are you having your period? Oh, don't come after your period's ended. And they don't see anything because after the period ends, the bleeding is going to disappear. So unfortunately, these colonoscopies have to happen while their patients are on their period.
Huh. That's good to
They need
know.
a tampon and just go ahead and have the colonoscopy to see if the inner lining of the rectum has any of these red spots. Right. So here, this whole thing that you're seeing here that I'm kind of cutting red, it's basically try to get into the vagina. But the back wall of the vagina. So just give me a second. Stop this for a second. So you see here, this is one of the favorite things that I use to explain to patients things in the office. So look, pubic bone, clitoris, bladder, neck of the bladder, urethra, vagina, cervix protruding into the vagina. So laterally, you have your fallopian tube and ovaries. And then here, in front of the uterus, you have a space. And then you have the bladder. Behind the uterus, you have a space. And then you have your rectum. This is your descending colon, sigmoid, rectum, anus. And then you have your tailbone. You have a group of muscles that go from under your pubic bone, around the opening of the urethra, around the opening of the vagina, around the opening of the rectum, and touch your tailbone down here. And that's called your pelvic floor diaphragm. So after this patient had a hysterectomy, when they did her hysterectomy and they took out her uterus, what happened in this case was that this portion right here, like in this space, had endo. So what they did is they just removed the uterus and they joined this to that, but left the endo in place. So now at the top of the vagina, right, now you have something that looks like this, but has endo right in the middle. So every time she's and it just looks like a tiny spot. And every time she's having a period, she would bleed. But the thing is, when you're looking at them through surgery, you're only seeing, like, before in the office, if they're not bleeding actively, you're only seeing the tip of the iceberg. And then this is what I need. So we start to go in behind this and just cut into this nodule. So what we're looking at right now in surgery is we're looking at the camera is right here. Like I'm right on top of the rectum so that I can see where this is. And I'm using the CO2 laser, which is kind of the advantage of it, but of course I'm biased. This is what I love, is that I can see the thickness of what I'm cutting. And I can make really tiny changes. But here, I see the nodule and I'm already made a hole into the vagina so I can see where this thing is and kind of shave as much of that vagina as possible before. Because I want to remove that whole thing, but I don't also want to, I don't want to give her a 2-inch vagina.
Right.
So I'm shaving around this whole area after identifying. So I'm cutting right up here was nice and pink and removing this whole, this feels like rock hard. So this thing that you see over here, that's the vagina, right? That's the inner lining of the vagina. So I'm identifying where does this rock hard mass protrude into the vagina so I can cut around it, right? And that is really close to the rectum. So in this picture here, you have the rectum to the right. So I have a rectal probe deviating the rectum to a side, and I see this whole mass that's basically eating into the vagina, but if it stays that way for longer, it's going to eat into what?
The rectum too.
The rectum. Right? So then I have to shave these things really closely so that I can remove the whole nodule intact. So let me see. Okay, so this is that whole nodule being removed. right? So after that's being cut, then it's huge. Again, you only see something that's very, very tiny.
Right.
But then once I finish that portion of the surgery, I'm just touching the back of the vagina to make sure it's nice and soft, because it's supposed to be soft and fluffy, right?
Right.
But what happens when I'm doing that using these laparoscopic skills? That what happens is that you can tell that some of the muscle of the vagina or the back wall of the vagina still feels hard and nodular. So I decide to go after it and try to shave and make the back wall of the vagina a little thinner, because I'm feeling a lot of hardness around it. And as I'm doing that, you'll see here in a couple of seconds that I'm just using the technique of like cut a little bit and reevaluate. And then as I'm doing that, you'll see here that I'm going to find that. You saw what that was?
Yep.
So that.
Blurp.
So this is literally a pocket of endometriosis that has not made its way through the surface.
Yeah.
So if I would have just removed that nodule and not inspect the whole vagina, she would have been back here in another year with more vaginal bleeding.
And it didn't even take you that much longer to make sure that you got it all.
No, it literally took me an extra 10 minutes.
Yeah.
Right.
So when we're dealing with patients with endo and surgery, our goal is to do what? You do the surgery, you remove all the endo that you can from everywhere.
Right.
And if she needs a hysterectomy, you do it after you removed all the endo. Right? Not like, oh, remove take out the uterus and then be done with it. What happens to a lot of patients after they have a hysterectomy and they go back to their regular GYN? I just had a patient called me crying the other day because I did her surgery and she was pissed that like her primary GYN did not recognize all her signs and symptoms, and she had a hysterectomy. She kept her ovaries because I didn't want to castrate her, and her pain was fine. But then she went to get like an annual with her primary GYN, and he says, "Well, I mean, you went to him to have your endo surgery, and he did a hysterectomy, so you don't need to see me. You can just go to a primary care from here on out." I was like, God, that's kind of... So he literally kicked her out of the practice because something that he didn't believe she had endo.
He was like,
and he didn't validate her at all.
No.
Right.
So just because somebody else, his ego was hurt,
I know.
Yeah.
go somewhere else. That's like that's
Gotta
if
change
that's
that.
not medical neglect, I don't know what it is.
Yeah.
I
Yeah.
don't know. And that's
We're
something
gonna-
that we definitely have to figure out a way to do something about that.
We
Yeah.
need to talk about that at some point because you and I talked about this, but we'll have to go down that rabbit hole another time. But I think we need to talk about what medical neglect is and figure that out too. But if we're having that problem here in the US, other countries that don't have the money or the resources,
It's crazy. Like so when I started to go down to do surgery and teach surgeons in the Dominican Republic to do some of these surgeries, like what I heard that people were saying behind my back is like, why does he want to come here? The Dominican Republic doesn't have any endometriosis. And I was like, really? Is it the mangoes? Like what? Really? You guys don't have any endo? And then that person that told me that there's not enough endometriosis in the Dominican Republic, 2 of his patients contacted me. And I told him he had seen that I posted something about diaphragmatic endo. And he says, like, is that real? Like, patients don't have that, right? And then I operated on 2 of his patients, and both of them had diaphragmatic endo. And I wanted to say, you see, but the only thing I can say is like, God damn it.
yeah,
Like they were complaining about this. If you look at your records that they showed me, because we asked for their records, right?
right.
So they're complaining about like, oh, I get a lot of like upper belly pain and pain behind my breast, especially the right breast. Because that they tell you how in their own language how things are.
Right.
Yeah.
For the last like 7 years that she saw him, she was complaining about like right breast pain, but he did a breast exam, her breast was fine.
Right.
And then we go in and she's like bleeding like horribly.
Oh,
It just makes you so frustrated, I'm sure.
It
And
does.
angry. It's not just frustration, it's anger sometimes, like this righteous anger, I'm sure.
Yeah, it does. It does get you fired up. It does, get you in a bad mood.
Yeah.
But we still have to do it for them,
Yeah.
right? It's not like I'm not doing this. And like thank God, like the other day I was here at Atlanta and Dr. Sonora said, hey, if you can help some patients in the ER and do some stuff, just go ahead and do that. And that's another reason why I came down here, because I can still do a lot of charity work
yep.
and continue to teach. So we went there. We were in Santiago, which is one of the second largest cities in Dominican Republic, and we're able to do some charity endo cases, and then the patients were like phenomenal. Absolutely no cost, totally free for those patients, so that we can get some of the surgeons in Dominican Republic also interested in doing in identifying patients early.
Yep.
Because one of the things that I tell them is like, hey, dude, doing diaphragmatic endo cases, it's like cool. It's like, oh, a notch on my back, or it's like this super cool thing. But we love doing them, but we hate that we have to do them.
Right.
Yeah.
Because there's no point. It's stupid. It's like we know that the patient has a disease.
Yep.
Then she is 15. She's complaining about the same thing over and over again. But suddenly, because she's not a breeder now it's important.
Yeah.
But like she was, getting dumped by her boyfriend at 17 because she couldn't put out because it did hurt too much.
Yeah.
Or because she had,
Dramatic.
or that, well, she was like 22 and she has a boyfriend that she loves. And then she feels bad about it. And she's like, you know what? Sex is going to kill me, but I'm just going to give it up because I don't want him to go look it up elsewhere.
Yeah.
Like that type of trauma, that self trauma that you're also inflicting on yourself, right? Because you love your partner and you want to please your partner, but you understand that doing that, it's going to take you out of commission for a day or two.
Exactly.
So what does that do to your self-worth, to teenagers, right? So my goal is to we need to start identifying patients early.
Yeah.
Very early, preventing them like if you see all my videos of teen endo patients, the last 5 years, there's been one patient that was been sub 18 that needed a bowel resection. One. And we do around 50 to 60 a year.
Yep.
Right. So in 5 years, if one teenager, means that we need to get them while they're teenagers.
Yep.
So I think that it would be the best bang for our buck, I would say.
I would agree with that. That's why I'm always looking at my girls.
Yeah. We have this conversation often because she has 2 girls and I have a daughter. And, we talk about this often, we're very aware of their health issues. We also don't want to be overly is it this? But also know, is it this? And always keep that kind of in the back of our mind of checking in if things align or don't.
Yeah.
Which is why we're doing what we're doing, is because, help get the word out for our girls. And hopefully, if things can get caught sooner for this younger generation, then they can have a much better life than waiting 20 years, which is what it was for me to get relief.
Yeah.
Which absolutely 1000% sucks, correct? Because if you know for a fact that a patient has these issues,
right?
If you figure this out early, right? If you figure this out early, that means that patient is not going to undergo the trauma, the hurt of having to go through all this.
Yep.
Right.
I mean,
what does it do? You remember all those traumas, and then on top of that, those traumas that you suffer from. I mean, thank God that you guys are kind of being the guardians of your daughters. Not that we need to crucify our mothers and our grandmothers, when especially because we have so many patients that have chronic pelvic pain for such a long time. But then grandmother says, "Oh, my pain was really bad when I was young, but I just had some kids and I was good." Done. And then grandma, how old were you when you had your first child? I was 16. I was like, oh.
Well,
right? I'm 35, you know, right? Or I'm 30 and I wanted to like finish all these things because time changes.
Right.
Times change, right? So like there's lots of grandmothers that started having kids at 17, 18, 19.
Yep.
But now you're like 25, you finish your career, now you want to travel, do all the stuff, and suddenly you're okay, I'm 30. Now I'm someone I want to have. Like I want to now get the family, now get the picket fence and get all that stuff because I needed to feel fulfilled as a person
Right.
before I can pour my love into a child.
Yeah.
Right.
And then suddenly now that you had all those complaints and they ask you about your history.
Right.
Oh, you know what? You must have had endometriosis back then, but we didn't care because you weren't thinking about getting pregnant. Now that you can get pregnant, now it's an issue.
Yep. I mean, and they didn't know. My mom had no idea. We talked to my mom a while back. We did an episode with my mom about this, and she's like, I had no idea. I didn't even know what endometriosis was. I'd never heard this word, and I came from a pretty small town. And she's like, I'm not sure the doctors would know what that is.
So what did they used to call women back in the day when they had like a lot of pelvic pain with their periods and stuff like that? Hysterical, right?
Yeah.
They had hysteria. They were crazy.
Yeah.
Like nausea, vomiting, all those stuff, like doubled over in pain, demonic possession, and all that other stuff with their periods, right?
Yeah.
Right. So
you don't want to be labeled with that.
Welcome to the age of lobotomy. Like a lot of different things. Like there's a lot of different things.
Yeah.
And women have had to endure significant pain.
Yeah.
Right, throughout life. So it's important that we have providers and people that are validating those concerns, are identifying these things early. And that's my goal for all this education that I do, is because even though I love doing complex cases,
right,
I hate that we have to do them.
Yeah.
Right? That's the point. Like I hate that we have to do them.
And it's interesting because like I think you posted this of the gal that was talking about the guy that had the vasectomy, who they offered him a sandwich to give him comfort. And I was like, what? I've never in a million years.
And I called my friend. I called a friend of mine that had a vasectomy. And he's like, no, I don't want to have any more kids. So I'm just gonna go ahead. I was like, dude, I was like, I had no pain. Like I was cool. They gave me soda. I was there for some time. And they made sure that for the first 3 hours, like 2 hours, I was cool. They gave me some food and I was like recovering in a nice area. And here I am thinking, I'm horrible. We used to put IUDs in patients. Like, it doesn't hurt that much. It's fine.
Yes. That's what I was going to say.
It hurts. Like we're pushing something through your cervix, which is a portion of the body that has an incredible amount of nerves, pain receptors through wazoo. And we like most of the time don't even give you like anything.
When I had mine, I almost passed out. My face went completely white. She goes, you okay? I'm like, no, yes, no. Like I didn't know what to feel because we are conditioned to be strong and to pass off pain and to take it. And I almost vomited and almost passed out. And she had to stop. And I remember she was like, okay, well, just sit up slowly. And then when you're ready, get dressed. And I was like, that's it.
Yeah.
And I will say she was a little old school with some things too. So it was pull up the bootstraps and let's go, And so I think, I don't know. I wish that we approached pain, and we talked to Beth Dupree about this, about pain and pain science, and even figuring out different modalities for pain, because it's a real thing that is not touched a lot with the endometriosis world. We just have to live through it most of the time. Yep. And there's surgical, but there's a lot of other stuff going on. So I don't know. I think that's something for me that I feel a little bit passionate about, is just having compassion, bedside compassion.
I think also a lot of GYNs in not only the US, but in the world, sometimes end up having compassion fatigue, and it's normal. Right. We're also human. We have some issues, but it doesn't mean that we have to vomit our bile into patients, right? If you need to take a break, you should definitely do that. If you need vacation so that you are empathic, you should definitely do that. For me, like when I'm reaching my point that I'm tired, the only thing that gets me through and centers me is, what if this, I just say to myself, what if this is my daughter?
Mm.
And I was like, that's it. That's the only thing that gets me like, you know what? It's not her. It's like nobody wants to be in pain.
No.
Like, who wants to live in life in pain? Like, and I tell my patients, like, I mean, if you're telling me you're in pain, I'm going to do some tests, but I have to believe you.
Yeah.
Yeah.
Right? Nobody wants to not function. Nobody wants to like not have fun. Nobody, and it's I'm one of my biggest point of satisfaction is that when I'm like, after surgery and I give the patients the pictures, like I basically after surgery I sit down with their family members and go, okay, this is her storybook. And we take her phone, right, and go put the pictures right there, and then go record. Picture number 1 is this, and I do a video for her. And at the end of the video, my favorite phrase is, "Congratulations, you're not crazy."
Mm.
And then a lot of the times, the partners are like, "What? That's there? That was there? Oh yeah, this is her uterosacral. That's her other uterosacral. You see how this looks nice and pink? You see how this is beefy red inflamed? And every time you go deep and she's saying it hurts or there's something, she's not being extra or a baby." The only way a man can understand what like having penetration and having pain in the uterosacral is the following. It's like, I heard somebody say this the other day. It's like, you would have to like staple your testicles to your legs and go running.
That's what Adam Duke was saying at the
I
summit.
think Adam was the one that said it. Yeah. The only way. Or every time you go in, somebody does this, like flicks your testicles. That's the only way that you can feel the type of pain that going in feels when you have your uterosacrals totally scarred down.
Yeah. But I think we get apologetic for feeling the pain, and we apologize to patients.
What you just said earlier.
Yeah.
Just because you just said it right, because women are conditioned to take it. Right. And nobody wants to be the weak link.
Right.
Especially women. Like nobody wants to be like, oh, I can't do this or something like that, because you feel that people are going to think that you're less than.
Right.
Especially when you don't have a diagnosis. A lot of patients tell me before surgery, it's like, what if you don't find nothing? And I was like, I'm going to tell you something. I'm taking you to surgery thinking that you have endo, but I am wishing to God that I'm wrong.
Yeah.
Like I'm wishing to God, like but what if it's not endo? Great. We can focus on figuring out 50 other things that can give you pain.
Right.
But,
about how many patients would you say you've taken back and it was not?
So when we reviewed our data at SLU, I think that our rate of finding endo was close to 90%. But I also got a lot of heat from that from some of my friends over there, because they're like, well, if you're finding endo at a close to 90% rate or above, that means that there's a lot of patients that are not meeting your high standards for surgery, that are not undergoing, but they may still have endo. And being devil's advocate, I understand what they're saying. Because if I need patients to meet certain criteria for me to take them to surgery, because I don't want to take a person to the operating room and say, oh, it's not endo. But when it's not endo, it's very likely, it's usually IC and adenomyosis. So it's very unlikely that we take a patient back for surgery and they're like totally pristine normal.
Yeah. There's usually something going on there. I mean,
there's usually something going on.
Because no one's going to go in and pay all this money to have something done and be I mean, it is minimally invasive as it is. It's still invasive. And it's not like
there's risk. There's massive
risk. Absolutely. And so no one's going to want to pay for that and not think that there's nothing going on. Like
I've been fortunate enough to meet doctors from different countries, and phenomenal physicians that are helping lots of patients that don't have the possibility to come here to the US. Phenomenal doctors in Mexico and Brazil, that are kind of taking care of that population.
Right.
And I feel really happy to have met them and understand and see the stuff that they do around the world, especially in Central and South America, that basically need so many physicians. There's so many women that are suffering from this. And to know that they're taking care of their population in their respective countries and great. and in a great way. It just fills me with joy, you know.
Yeah.
So that's good. That's what we want. We want patients to, which is kind of one of the reasons I love the Nook. I know that maybe a lot of doctors are not happy about Nancy's Nook or anything, but I love it. You know why? Because when you go to a restaurant and it's bad quality, you go in, this place sucks. Right? But there's nothing like that for doctors. We should have, especially endosurgeons. There's a lot of surgeons like, oh, I do endosurgery. But then patients are having like surgery 2, 3, 4 times in a year. I'm like, how are you? And then after surgery, you're just basically putting them on Lupron or Alyssa and a whole bunch of meds. Like, I mean, how? And then you go back really soon, or I've seen just lots of patients that 2 months later, their pain was back like they never had surgery. And then they were told that everything was fine. And then we go back and we find stuff like this.
The work that you're doing, though, and the compassion that you share and with your patients and with the endometriosis community gives us life, because and help, but it's just, it gives us life because it fuels us to see a doctor care so much that he's putting himself out there more and talking about this. And that's why I don't remember who I was telling. I was like, he's my favorite. He's one of my favorites, because your heart and your compassion, they walk in before you do. And it fuels us as people who speak about this and try to give people tools and to put in their tool belt to get the help they need. It fuels us to continue doing that, but it also fuels those patients that you've helped to know that they're not crazy. And you are changing the world, and you're young and you're capable, and you're going to change the world. Just saying.
The whole young thing is I moisturize, you know.
Is it all
the sun too?
It's the sun.
Sun and the moisture.
It's the sun, but you know, my wife is just, she's gotten me on this retinoic acid and and a whole bunch of stuff. And I was like,
potions.
The freckles are not going to go away, so just forget it.
Right.
It's the potion.
The freckles.
My husband's like, how many things do you need? I'm like, if you want me to look good long term, this is more for you than me. And he's like,
the wife. It's the wife.
Right?
Yeah.
Thank you for showing those and for taking your time and being amazing and
so educational, and keep doing what you're doing.
Thank you for the opportunity for letting me talk to you. If you guys let me talk, we'll talk here forever.
I know. Well, any day.
Yep.
You're welcome anytime. So, anytime. Thank you.